This is Dimitar Nikolaev in the... yes, sorry. So our aortic thromboembolic intervention is in complicated case. Sorry, Vitko. Welcome.
I'll try to explain.
Neurosurgeons.
Okay. See, I'm in front of neuro interventionalists almost. I will talk about the endovascular treatment of thoracoabdominal dissections and aneurysms and the complications we met. This is the purpose of this presentation, to share some of the most challenging cases and complications encountered in the management of thoracoabdominal pathology. We know that the standard endovascular treatment of thoracic and abdominal aortic aneurysm includes TVAR and EVAR, which are well-established modalities nowadays. But when the big arteries are involved or had to be covered, we have more complex cases like this, when we have to cover the arch vessels or the renal visceral segment. So in these cases, we have options for open surgery as well as hybrid surgery, like in this one, in which we performed for this giant arch and thoracoabdominal aneurysm, first bypass from the aorta to the all three branches of the arch, and after that we cover the aneurysm. And the entirely endovascular options include different kinds of modalities, like fenestrated or branch devices on the one side, and the chimney periscope sandwich, some of parallel grafts to preserve the main vessels. So in last 3 years we adopted the first idea very much, and we are using only or most of the times physician-modified grafts because of the lack of custom-made devices in our country. So our experience includes 45 fenestrated or branched endovascular aneurysm repairs for complex AAA and thoracoabdominal aneurysms, as well as 5 cases of fenestrated TVARs, 1 PMEC and 4 in situ fenestrations. And we very often also use modification of the grafts, of available grafts for preservation of the internal iliac artery. This is one of the cases we showed previously. So, why the complications are important and more often in FIVAR procedures? It's because we have many times bigger devices compared to standard one, and we can expect access complications. Also, manipulation in the arch or with the visceral vessels can result in target vessel complications. I said already that we use mainly physician-modified grafts, so we must accept the risk of some wrong measurements, which we are doing by ourselves, and malposition of the fenestrations, and also the risk of infection is not negligible. And the last reason is with extensive coverage of the aorta, we can meet also cerebrospinal ischemia. So, I tried to look at all of our complications, and there are too much maybe. You can see we had 1 access complication, while 2 malposition of the grafts, in fact 2 unintentional coverage of the left common carotid artery, malposition of the SMA fenestration, 1 retroperitoneal hematoma, acute myocardial infarction, and 2 cases of cerebrospinal ischemia. The first 4 cases were successfully treated, I will show you, and we had problems with the other 4 cases. So this is the first case, 78-year-old female with big arch and type 1 thoracoabdominal aneurysm after bento procedure. We didn't have good proximal landing zone, but the prosthetic graft implanted by the cardiac surgeons. So we have to do 3 fenestrated PMAC, thoracic PMAC. We used preloaded reinforced left subclavian fenestration, which helps very much for the very good orientation of the graft and positioning of the graft. And in this case, because of this preloaded wire, we had to use 24 French sheet to accommodate the 22 French delivery system. The procedure itself went very smoothly with this very good result, but when we tried to remove the big sheet, we had this. So it was something like stripping of the whole external iliac artery, which came out with the sheet. We were lucky to have the wire inside, put balloon immediately, and after that implant self-expandable cover stent fixed proximally with balloon expandable cover stent and anastomose directly to the common femoral artery. This is the groin you can see, and this is the result. This is the control CT at 1 month. You can see the good isolation of the thoracic segment of the aneurysm and also the well-patterned right external iliac artery. The second case is of a type 3 aortic dissection, beginning very close to the left subclavian artery. We decided to use in situ fenestration. You can see now the graft in position, retrograde puncture of the graft with specific device, implantation of a cover stent, but we had some doubts that probably we've partially or entirely covered the left common carotid artery. It was not very well visible. We checked with duplex and saw that there is a problem. Punctured retrogradely the carotid artery. You can see that there is almost no flow there. After that, it was easy to go between the graft and the aortic wall and implant a chimney with this final result. The third case is of a 68-year-old male with juxtarenal AAA with chronically occluded left iliac artery. We used Endurant 2 aorto-iliac graft because we didn't need to revascularize the left leg. The patient was absolutely stable. So right femoral and left brachial axis in this case. You can see there is no neck infrarenal. We go with 3 fenestrations to cover to fix the graft proximally. It was easy to cannulate the right renal artery, but we found some difficulties in cannulate the SMA and the left renal, and it took maybe 2 hours to try. And finally, we decided to go for a retrograde access with laparotomy and direct puncture of the SMA. You can see now that there is mismatch between the fenestration and the ostium of the artery, but with retrograde manipulation it was possible to go from the artery to the fenestration, connect it, and put a stent. After that, it was easy to cannulate the left renal artery, and this was the final result. So the patient went through acute mesenteric ischemia reperfusion syndrome and acute renal failure, which required dialysis for several days, but he survived. In this case, we had inaccurate measurements of fenestration locations, wrong decision to cannulate the renal arteries first, And so the lesson we learned is that we must probably measure twice and cut once, and always to cannulate the most important artery, which is the superior mesenteric in these cases. And opening the abdomen should not be delayed if there is no other way to restore the mesenteric blood flow, because the life of the patient depends on this. And the last case I will share is a 60-year-old male with pararenal AAA. Also, we used 3 fenestrations for this case. The procedure went very smoothly, quick, but the next day we found hemodynamic instability, hemoglobin drop, and on the CT you can see there is a big kidney hematoma as well as retroperitoneal. We decided to embolize the whole kidney in order to stop bleeding, but it was probably too late, and this patient, we lose him a few hours later. So what happened? We were very happy with the fast procedure, but we didn't exchange the aggressive Terumo wire with dedicated rosen after the cannulation of the right kidney. So what happened really was perforation of some of the distal branches of the kidney, and probably this was the reason for this result. So the lesson is don't skip important steps and use the right devices for the right aims. I think with this almost 30 cases, we've met a lot of the complications described in the literature. Maybe we don't have only acute target vessel dissection occlusions, but what can I say? In conclusion, there are clear reasons why complex procedures have more complications compared with the standard AVARs and TVARs, and thorough knowledge of the FIVAR principles and techniques is essential. And every case contributes to the learning curve in which we are, and the greatest lessons often come from difficult and unsuccessful cases. That's why complications should be carefully analyzed and openly discussed. Thank you for your attention.
Thank you. Any questions or suggestions? Remarks? No? Yeah. Other?
Yes. I'm sorry? For carotid retrograde access, right?
Yeah. How did you close the puncture?
We used ProGlide, ProStar. 6 French sheet under ultrasound guidance, and after that also under ultrasound we checked the closure. It was absolutely perfect. Of course, we were ready to go for a small cut down and to make a surgical stitch if there is hematoma or something, but we didn't need this. We used several times puncturing the carotid directly, and with ProGlide it's very, very good, simple, in healthy region of the artery.
Okay, thank you.
Thank you.
He's here. Yes. Sure.
There was something on Panopticum of complications.
Hello. We are not so many people. We are not so many people, but Dr. Iliosky knows that I can speak more than 10 minutes. I will go, I try to be as fast as possible here. There are increasing number of peripheral intervention all around the world, with complication rate you see not so low, 3 to 6%, and 1-2% in hospital mortality. and some other complications like systemic, like contrast-induced neuropathy. This is the CIRSE classification, which starts with the resolvable during the procedure problems to the fatal grade 6 death. If your center is with a high volume, the volume of complications grows, but as was taught by Roger Federer, the more I train, the more I win. That's why when you work hard, you can manage most of the complications. These are familiar things, the types of complications, and I'll cover some of them. Access site with the risk factors and management. The most of the cases are access site complications, and they're manageable. A lot of them are manageable in the cath lab. Dissection, especially in our cath lab, when we are dealing with a lot of chronic occlusions, I mean distal iliac, femoral, or below the knee. The dissection method is one of the main methods for microdissection and subintimal recognition. That's why they are not so important in this presentation. That's why I'm skipping them. Vessel perforation is not so rare situation in our cath lab too, and the operator should be prepared with the skills and with the materials to manage this problem. Thrombosis is other serious problem. We have very long, very hard recognizations, and after that, like in this case, all of the stents and expected good result is gone. In this case, the patient was thrombolized 2 or 3 times, but after a few hours after successful recognition, the patient retrombosed. That's why because it was in another institution, they transferred to us, and we try angiojet recognition, and with the success in this case. I mean, thrombolysis is one option of acute thrombosis intraprocedural, and some aspiration methods are you should take into account, and with the good acute result. The territories iliac, femoral, and below the knee have specific situations and considerations, but iliac is more dangerous territory because a lot of problems there are potentially fatal. Here we have one attempt of recognition of left iliac artery occlusion, but we tried hard to guide wire for penetration, but we penetrated in the bifurcation a little bit to the right with the guide wire, but in this case, I am showing this case because a lot of operators should put cover stent directly. This case was resolved with the prolonged opening of the properly sized balloon. This is the result. We follow the patient. We were ready to put the cover stent if the problem persists, but in this case, only with the ballooning, it was possible to stop the bleeding. This is interesting patient. You can appreciate that the iliacs are strangely diseased, very small arteries, and we decided, I'm not putting the previous procedure, but we decided to stay very good result we achieved with the 5 millimeter balloon. But after several hours, he experienced abdominal pain. He went to the hemorrhagic shock. And you see, first we opened the balloon there. There was some manual compression because he was around 50 kilograms, and it was possible. But the waiting was to have a sufficient amount of covered stents. And after we received them, you see the good result. And after a month and a half in the ICU, the patient was dismissed, but it was a very tragic for us case. Femoral complications, as I mentioned, they are mostly rupture of the vessels. Here is one intervention, antegrade approach, SFA recanalization. You see, complex case, but nothing special. But after the ballooning, very calcified, you may appreciate the calcium. After ballooning, there's a rupture. We thought that it will stop after putting the self-expandable stent, but nothing. The bleeding persisting. We tried to find a side branch, but it was not the branch, and we put a cover stent there. This is simple, not so simple intervention. And when in the attempt, this is popliteal segment, at the attempt of recanalization, we go outside the vessel, went outside the vessel. And this is our second case in the popliteal segment. It was solved by coiling. We have friends with the coils, and we put the coils, and this is the result. Very good result. Without any other, the patient experienced pain. The big hematoma was formed in the popliteal segment. That's why it was necessary to perform it. Below the knee, also, this is the recanalization in the popliteal segment and below the knee. You see the rupture in the tibioperineal trunk. Again, with the coil, we solved the case. You see a good result. These are 3 algorithms for solving the problem, but you should have experience, you should have friends, as I mentioned, with some of materials and skills, because sometimes it's not possible to cover all the problems. You should start with the measures and to escalate to the most of the problems in our field are solved by vascular surgeons. at the end, but we try to avoid them and to cover all the problems with the endovascular materials and skills. This is something different. This is a STEMI patient with PCI, and you see the temporary pacemaker put it. The patient is with STEMI, as I mentioned, with dual antiplatelet, with additional drugs, heparin and so on, and the big hematoma in the groin. That's why that was some different side case, but we saw it again with the covered stent here, because otherwise we should have problems with the big hematoma and patient which is anticoagulated, and with a lot of problems. That's why I'm putting this patient. These are materials and the skills. Covered stents are must, especially in the iliac segment. Balloons, they are not put in the, they are not in presentation, but there are in the United States. There's rescue balloons. You can put them in the big bleedings below, in the lower part of the aorta, can be put it, and for 1 hour can be stopped bleeding for any kind of bleeding. You should have thrombectomy systems and experience with local lysis in the in thromboembolic situations and low reflow, and skills and re-entry devices when there's dissections. These are takeaways, but I'm done with my presentation. Thank you so much.
Any questions from the audience? Suggestions? And thank you for the presentation.
Thank you.